sleep. Aptly named because I imagine all of you will be suffering from some form of postprandial sleep depression. So to kickstart us off, we have a presentation by Dr. Shimala Withana. She's a consultant respiratory physician at the Royal Brompton and Harefield NHS Trust, United Kingdom. I'd like to welcome Dr. Withana to present on how to evaluate sleep-disordered breathing.
Thank you very much. I hope you can hear me. Yes. It's an absolute pleasure to be here speaking to you. And if you recall what Professor Gary Lee said yesterday, is the peak postprandial time of maximum daytime somnolence, and we have been given the task to entertain you on sleep medicine. Now, over the course of the last decade, sleep medicine has evolved, and I know you've had lots of talks in the past. You've had lots of talks in the past about CPAP, so I've decided to pay a bit more attention onto other modalities of treatment, but I'll be focusing very much on patient assessment, not so much on diagnostics or patient management. And I need to give special thanks to my colleague, Professor Yogstier, who will be joining us later on, who will be talking a lot more on the recent advancements. Oh. So, what do I need? Thank you. So to summarize my talk, I will be going through the spectrum of sleep-disordered breathing. Then we'll move on to orodental assessment and mandibular repositioning or mandibular advancement therapy. We'll talk a bit on upper airway assessment and ENT surgery, about craniofacial abnormalities and maxillomandibular surgery, chest wall deformities and thoracic surgery, neurological and genetic disorders. We'll touch a bit on obesity, endocrinology, metabolic syndrome, and bariatric surgery. Now, this nicely sets the platform for you to understand that sleep-disordered breathing or sleep and ventilation and lung failure is a multidisciplinary approach. And it nicely knits well with all other subspecialties within respiratory, not just respiratory, but in many other disciplines. So it's important as respiratory physicians that you understand your patient needs to be assessed, in that you can deliver a more personalized approach, as each individual could have either one or more of these pathologies. The spectrum of sleep-disordered breathing is growing, and the definitions are evolving with time. Now, if you look at the key pathology in how the sleep architecture is disturbed, you've got four main abnormal areas: reduction or cessation of airflow, hypoxia, and hypoventilation. Those are the key pathologies, and you will find in a single patient, you can have more than one pathology. Now, I've clustered obstructive sleep apnea, hypopnea syndrome, position sleep apnea, and REM OSA into one group. The next group, central sleep apnea, is where there is loss of central respiratory drive, which is seen in certain neurological conditions, cardiomyopathies and heart failure, certain drugs. So it's important to understand and identify the underlying etiology. Central sleep apnea can also occur mixed with obstructive sleep apnea. I'll talk a bit more later on obesity and nocturnal hypoventilation syndromes. Upper airway resistance syndrome is also an increasingly identified and debated entity. It's presence in the same way as OSA you would have snoring and daytime somnolence, but the sleep studies will not score in the same criteria as OSA. So it's a debated entity. Growing in experience, you will possibly come across these patients, usually with lean, tall neck. It can sometimes overlap with other conditions, such as periodic limb movement syndrome. Nocturnal hypoxia is an important entity for you to recognize. Nocturnal hypoxia without hypoventilation. You need to think about conditions such as pulmonary hypertension, heart failure, anatomical shunting, and other non-respiratory conditions like anemia. Now, overlap syndromes associated with other respiratory disorders such as COPD and interstitial lung disease is an important aspect in lung failure and will be dealt as a separate topic by our last speaker. I would say OSA and OHS is by far the commonest topic that you've come across and had talks on. We all know that CPAP therapy or mask-based treatment is the gold standard. And I think the issue we have is more related to the fact that although CPAP is the gold standard, there are problems in tolerance, there are problems in acceptance, there are problems in affordability. Now, the key message here is history of how you identify these patients in your day-to-day practice. So excessive daytime somnolence is actually the key history that you need to be focusing on your patient for all across the spectrum of SDB. There are measures that help you, such as the Epworth Sleepiness Score, but I think a good history to identify how this affects your patient's quality of life, how it affects their social life, how it affects their occupation and their driving safety. And as we know, driving-related accidents related to sleepiness is increasing. So I think it's important that you identify these factors, because the more symptomatic the patients are, the more receptive they are towards treatment. A little bit on nocturnal hypoventilation syndromes. This is an important area, particularly with relevance to acute and chronic lung failure, particularly your patient who comes and becomes decompensated overnight. You need to be thinking of nocturnal hypoventilation. Consider drugs such as opiates, benzodiazepines, neuromuscular disorders. In the acute phase, even conditions like acute myasthenia or Guillain-Barré. In the chronic forms, the chronic neuromuscular conditions, restrictive chest wall disorders, and other rare causes such as congenital and hypothalamic syndromes. Now, there are differences between the OSA-OHS spectrum in terms of definition and how you look at the CO2 levels, how you look at the stop breathing or the apnea events, which will be dealt in a bit more detail by my next speaker. Now we move on to an area of treatment that has been around for more than 2 decades, but it's still new to Sri Lanka. So oral appliance therapy or mandibular repositioning therapy is an increasingly recognized and evidence-based way of managing patients with sleep-disordered breathing. It's a very simple device with a very simple mechanism, but it's very effective and cost-effective. So we as respiratory physicians, we need to coordinate with orthodontists who are interested in this area in order to develop this. So mandibular repositioning devices work by a very simple mechanism by pulling your lower jaw forwards and creating that extra angle at the back of the throat to improve the airflow, and in doing so, to treat the underlying apnea. It treats the sleep apnea across the board, across all severity groups. and it also is a very useful treatment for problem snoring and also in upper airway resistance. Now, there are very simple devices which are called boil and bite devices, which you put it in hot water and mold into your jaw, into more complex, tailor-made devices which should be done by an orthodontist. And there are even devices with software that can monitor your airflow, monitor compliance, monitor the AHI. So it's a very rapidly evolving field. But we need the help of the orthodontist, and you need to be aware of how to assess your patient who's suitable for this device. Upper airway assessment is a must in the respiratory examination, more so for sleep-disordered breathing. Now, you're all but familiar with these anatomical abnormalities, the enlarged uvula, tonsillomegaly, and macroglossia, but also be aware of the tall, lean individual with a small airway, maybe a bit of a high arch palate, marfanoid body habitus. That group of patients also can have very severe sleep apnea. Now, you're also familiar with the upper airway malempathy score grading. So these are important assessment on your initial review of your patient. The patients may not complain necessarily of STB, but if you do see these features, it's important to ask that bit of history. In addition to that, anything relevant to their upper airway nasal flow, any issues, nasal trauma, nasal blockage, rhinitis, all these aspects of history and examination will help you towards catering the treatment for that particular patient. Now, upper airway assessment and ENT surgery has evolved a lot. There is a technique called drug-induced sleep nasoendoscopy, or DISE, which is delivered by ENT surgeons who have a special interest in sleep-disordered breathing. Now, you can see there's a lot of interventions that's available and growing. I will not go into detail because my colleague, Professor Yogstier, will go in much more detail into these different treatment entities. What I need to tell you is that it's very important that we collaborate and coordinate the care with your ENT team. And I know in most places, respiratory teams work close with ENT teams, so it's important for you to know that these treatment options are available for your patient. Craniofacial abnormalities is another important examination finding. Now, these patients will not come and complain to you that they have this. It is an observation, and it's an important observation that you need to make. What I have highlighted on here are possibly the extreme forms of it, and the common ones that we list are micrognathia, retrognathia, prognathism, jaw malalignment, maxillomandibular hypoplasia, and low-set hyoid bone. Now, you may not necessarily see these in extreme forms as these pictures, but certainly the subtle forms exist in the patients groups you see, particularly the lean patients, and they do respond very well to mandibular devices, ENT interventions, and they do respond to maxillomandibular surgery. So it's important that you're aware that there is this group of patients, and if they do come with certain symptoms, it is important that you observe that how their anatomy is. Maxillomandibular surgery is also growing, and in the experienced hands, it can be curative when it comes to sleep-disordered breathing. Chest wall disorders is an important area, and I know our next speaker, Professor Vladimir Anikin, will be talking in a bit more detail. Conditions such as kyphoscoliosis, pectus deformities, sternal defects are important to be picked up in the early life and corrected if possible, and that then will prevent or delay later life development of nocturnal hypoventilation and lung failure. Now, I want to pay a bit more attention on the last bit of steroid-induced osteoporosis-related kyphosis. Now, we all use steroids either in inhaled form or oral form, so it's important, I think, that we are vigilant. screen our patients very early, make sure we start treatment early for potential prevention of established osteoporosis. This will then delay the onset of later life kyphosis, and kyphosis can then add to the underlying lung disease, adding to nocturnal hypoventilation and lung failure. Now, neuromuscular diseases, we all know, is very common to cause hypoventilation-related type 2 lung failure. And I've listed some mechanisms as to how it does work in different patients depending on their conditions. Regardless of the primary pathology, be aware of these conditions. There are lots of conditions in there that I have listed, but more importantly, we need to develop that rapport with the neurologist, because the early detection of these patients and early initiation of BiPAP therapy transforms their quality of life, improves their risk of developing lung failure, delays their mortality. So phrenic nerve palsy and diaphragm palsy I've listed on top simply because in a certain group of diaphragm palsy patients, you can actually correct it with the help of your thoracic surgeons using diaphragm plication, and that can sometimes be curative, particularly the post-op group of patients who get acute diaphragm palsy. Now, spinal cord trauma and cervical injury, muscular dystrophies, myotonia dystrophica, myasthenia gravis, motor neuron disease, metabolic myopathies, although rare, they can sometimes be treated with curative means, and certain neurodegenerative disorders such as Parkinson's disease and dementia are important to know, because if they do have sleep-disordered breathing, if you identify them, it's not uncommon for them to have excessive daytime somnolence. You can improve their quality of life to a large degree. Now, this is an example of such a neuromuscular clinic where the patients are treated with ventilators, and you could see not only are their quality of life and independence improved, they become economically productive and they have a much better quality of life. So we need to collaborate with our neurology colleagues in order to identify these patients early. Now, put genetic disorders, particularly because for you to understand that the initial mechanisms that I mentioned can coexist in a single patient. Now, Down syndrome, Marfan's, Ehlers-Danlos, and achondroplasia are common conditions. You all know about it. I'm sure you've seen these diseases. Now, if you take Downs, for example, upper airway abnormalities, they have macroglossia, they have soft tissue abnormalities, they have craniofacial abnormalities, they can have chest wall deformities, they can have muscle hypotonia, and they will have obesity. So all of these mechanisms will contribute to their sleep-disordered breathing. Likewise, in Marfan's, you can have high arch palate, again, soft tissue floppiness, they can have craniofacial abnormalities and chest wall deformities with kyphosis. They will also have muscle hypotonia. So in different groups of patients, you can clearly see it's not just one mechanism, it's more than one mechanism. And because other respiratory conditions are very prevalent, these patients can easily develop lung failure. Now, obesity, endocrinopathy, and metabolic syndrome is an important area. We as respiratory physicians, we use a lot of steroids, and we do come across steroid-induced Cushing's, type metabolic syndrome, type 2 diabetes. So we need to be working closely with our endocrine colleagues to identify these patients, manage them early. Conditions like large multinodular goiters, retrosternal thyroids, pituitary tumors, acromegaly, Cushing's, adrenal tumors, these are curable diseases, and you can treat and cure their sleep apnea if you search for these conditions and work closely with your endocrine colleagues. Now I've come to my last slide, but the most important one, I think. Obesity is the pandemic that we all need to address. Now, we as respiratory physicians, we have done our fair bit through the COVID pandemic to improve global survival. But obesity is a different pandemic which is uncontrollable right now. It's growing everywhere. So it's important that we address the lifestyle, nutrition, exercise. It's only spend that few minutes with your patients. BMI about 25 is not uncommon. So spend that extra few minutes with your patient to give that advice on importance of lifestyle and exercise and maintaining good BMI. Now BMI about 37, there is lots of pharmacotherapy for obesity. In the resistant group, BMI about 35, there is effective bariatric interventions. Now bariatric surgery has been around for about 70 years. NICE has approved it in England in 2016. In the at-risk, high-risk group, it is effective, it reduces mortality, it improves sleep-disordered breathing. Now on the left-hand corner, I have listed a group of conditions that can be improved if we treat obesity, if we treat sleep-disordered breathing associated with obesity. Now if you go through that list, there is cardiac failure, which includes left and right heart failure, ischemic heart disease, stroke, TIAs, cancer, road traffic accidents, extremely important, type 2 diabetes, atrial fibrillation, dementia, fatty liver, NASH, cirrhosis, chronic kidney disease, and pulmonary hypertension. How common are these conditions? You come across these patients almost every day in almost every other patient you see. Now, I've looked at the CDC classification of top 10 mortality, top 10 killers in the world. There's only 2 conditions that's not listed here, and that's COVID and chronic lung disease such as COPD. So this then tells us that we as respiratory physicians, we reduce the global mortality of the top 10 killers in the world. So this highlights to you the importance of our role in managing global mortality. Now, with that, I conclude. I've put some references for the benefit of the juniors in the audience. And for those juniors, you probably know me as a RCP international trainer. I've been training respiratory registrars since 2012. But there's only one caveat, it's through the government sponsorship scheme, but it is a very successful training program that I have in offer at my center. Thank you.
Thank you, Dr. Sharmila, for the elaborative talk about the assessment of sleepy patients. So now I call upon Dr. Dilisha Vedasinghe, consultant respiratory physician and senior lecturer in physiology, for the further how to interpret the sleep studies. Over to you.
Thank you very much, Dr. Rishi, for that kind words of introduction, and I may take this opportunity to thank the college for giving me this opportunity. I have been given a very difficult task to teach how to interpret a sleep study within 20 minutes, but I think I will skip the first few slides because Dr. Sharmila has described most of them. So I have no conflicts of interest. My talk will outline sleep-related breathing disorders and some of the definitions, the types of sleep studies, the important terminology, and how to read a polysomnography report, the basics. Because the expert is always once the beginner, so it's for the juniors. I will teach you the outline, and it's up to you to become the expert. Right, putting sleep-related breathing disorders into 2 broad categories, so we can divide them as abnormal breathing rhythm or abnormal gas exchange abnormalities. So the abnormal breathing rhythm is further classified into obstructive sleep apnea and central sleep apnea, where you see a disorder or abnormality in the rhythm of your breathing. And abnormal gas exchange can be divided broadly into hypoventilation or hypoxemia with or without hypoventilation. So as junior trainees, junior physicians, when we come across a patient with sleep-related breathing disorder or a sleep study, we will try to figure which box our patient will fit into. Is it sleep apnea with upper airway obstruction? Is it central sleep apnea with unstable ventilation? Is it hypoventilation with inadequate ventilation? Or is it hypoxemia where you see a ventilation perfusion mismatch and other associated disorders? Right. So sleep apnea, we all know the definition. You should have 5 or more apnea-hypopnea index with signs of sleep, or just 15, AHI of more than 15 to diagnose. Obesity, hyperventilation, as Dr. Shamila said, you should be obese. You should have a raised arterial or arterialized capillary carbon dioxide level, daytime plus nocturnal. So the definitions are all there. It's all in textbook. So I will not go through all the detail. Nocturnal hyperventilation syndrome, this slide Dr. Shamila went through as well. There are multiple causes. Obesity is one, drugs are the other, neuromuscular diseases are another entity, and advanced lung disease also can give rise to nocturnal hypoventilation syndrome. So the nocturnal hypoxia, according to the AASM guidelines, would say that if you have arterial saturation during sleep less than 88% in adults or less than 90% in children for more than 5 minutes, plus you don't have sleep-related hyperventilation symptoms, then you can score it as nocturnal hypoxia. And a nocturnal hypoxemic burden, that is saturation less than 90% for more than 10% of total sleep time, is quite significant. So moving on to types of sleep studies, the AASM, American College of Chest Physicians, and the American Thoracic Society have divided sleep monitors into 4 types. Type 1, type 2, type 3, and type 4. So in level 1, which is the gold standard, you have EEG monitoring, EOG monitoring, and EMG monitoring, plus airflow, respiratory effort, oximetry, ECG monitoring, and also the sleep position monitoring. And in addition, there will be video recording, and this will be attended polysomnography. Level 2 is of the previous rest without the attended polysomnography. Level 3 is what we see where we can do commonly, the apnea link test, where you measure about 4 to 7 parameters without EEG, EOG, or electromyogram monitoring. And level 4 is quite basic. The oximetry data will give you a hint whether your patient has any sleep-related breathing disorder. So this is just a picture of a level 1 study. And these are some of the level 3 devices which are available in the market. And the one here at the bottom, left-hand side, is the ResMed Apnea Link, which we have in multiple hospitals where we work. So the level 3 devices are quite simple, but we don't get the total sleep time is the only problem in level 3 devices. So we cannot rule out sleep apnea using a level 3, but it's very good as a screening test. Level 4 devices, the simple pulse oximetry. So the terminology in sleep medicine, I will not go through a lot, but you should know what an apnea is. That is cessation of airflow for at least 10 seconds. It is obstructive if there is respiratory effort, as seen here in the thoracic sensors, the chest and abdomen movement sensors. And there should be a drop of more than 90% of baseline airflow for us to classify it as an apnea, either complete or a 90% drop. Hypopnea, there should be a 30% drop in the peak signal, and it should last for more than 10 seconds, should be associated with a desaturation or an arousal. So mixed apnea is where you see initial part there is stopping breathing, and at the latter part you will see the respiratory effort coming in. And this entity, which is upper airway resistance syndrome, where you see a flattening of the pressure flow and snoring associated with arousal, but it does not fulfill the criteria of a hypopnea or a hyperapnea. Okay, so moving to our topic proper, how to read a polysomnography report. So we start with the patient demographics, because the patient will be one of your patients referred to a sleep study, or it will be a patient who comes with a polysomnography report coming to you for an opinion. So start with the demographics. So here you can see a 33-year-old male. The weight is 114 kilos and a BMI of a 37.7. So just at looking at the data, it's a male, middle-aged, and quite obese. So we would think, okay, could our patient have obstructive sleep apnea? You also should know the various scoring systems. So stop bang will tell us whether our patient is having a probability of sleep apnea or not. If the score is more than 6, very easy to remember, and it's in the internet as well. So then Epworth Sleepiness Scale, unless the stop bang questionnaire will tell you whether your patient is sleepy or not. So that's what it would say. So if you have a ESS score of more than 10, it means that your patient is sleepy, and more than 19 means that you have an excessively sleepy patient. So when we are going to make sense of the polysomnographic data, you know it has multiple pages of data. So we can start dividing it to 5 main sections. We start with the respiratory data, then the oximetry data, EEG data, EMG data with the visuals, and last but not least the ECG data. So the respiratory data, and the first thing a respiratory physician would look at is the apnea-hypopnea index. So that is all the apneas, all the hypopneas divided by the total sleep time. So here you can see in the first page, the apnea-hypopnea index here is about 119.5. So in my next slide, I will tell you how to categorize them. So do not stop by looking at this. Okay, my patient has severe sleep apnea, but this is not it. Your patient might not have severe sleep apnea as well. Don't stop at just looking at AHI. So how are we classifying it? AHI more than 5 is sleep apnea, 5 to 15 mild, 15 to 30 moderate, and more than 30 is severe. And as you can see here, the AHI is of this particular patient is almost 119, and then that means that the patient has severe sleep apnea. In this tracing that you can see here, the polysomnography report, this is how the airflow normally looks like here. The orange one here, just to press over. It is not working. I don't see it. Okay, thank you. Right, so here you can see it looks like a sinus curve, right? But in this patient, you can see that it has flattened. So the upper air part of the air, this happens when the upper part of the airway is having an obstruction or a reducing flow. So there is flow limitation here, but if this patient does not fulfill the criteria for a hypopnea or apnea, then we just call this a flow limitation because it is not normal either. So, and these events are called respiratory event-related arousals if these flow limitations ultimately would produce EEG evidence of arousal. So this patient would have microarousals during sleep, and now instead of the apnea and hypopneas alone, if you add the apneas plus hypopneas and the respiratory event-related arousals as well, we would get an index called the RDI, which is the respiratory disturbance index. Right. So the RDI in this patient is more or less similar, but having the respiratory the RDI different from AHI would tell us that our patient would have some symptoms suggestive of upper airway resistance as well. So the respiratory event index, now you know in the level 3 studies, you don't get the total sleep times, what you get the total recording time. So when you use the total recording time to calculate in level 3 studies, we call it the respiratory event index. So calling it apnea-hypopnea index is incorrect when you are using a level 3 study. Now, next you should look at the positional sleep apnea. So, in your sleep study, you will see, depending on the position, what is your apnea-hypopnea index. So, we call it positional AHI when the supine AHI is at least twice as the non-supine AHI value. Here you can see the supine AHI is 37.5, the non-supine is 17.6, and this patient probably has positional AHI. So the therapy, positional therapy, which I will not go into in detail. Next, we are looking at the REM AHI. So in your sleep study, you will see the amount of apnea-hypopnea events during the REM sleep. So here you can see that the AHI of the patient, the total AHI is 6.6, but during REM it is 42.0. So this patient has a high REM AHI, but the total sleep study will tell that it is just mild sleep apnea, but the patient would behave probably as severe sleep apnea. And then central sleep apnea, you look at the central scores. This sleep study has no central events, but if the central events are more than 5 per hour, it is significant. And if it is more than the obstructive events, we call it a central predominant sleep study. And also, if you have significant central events, you need to look at for Cheyne-Stokes breathing pattern in the sleep study. Right, moving on to oximetry data. Next, we look at the oximetry data. The ODI, the oxygen desaturation index, is what we look at. So if it is more than 5, again, it is abnormal. And it's not the only thing we look at. We also look at 3 more things. The mean oxygen saturation, which should always be more than 90% if normal. And next we look at the lowest recorded saturation, and then we look at the hypoxemic burden. So here you can see the mean oxygen saturation in this patient is 89.4, so it is low. The lowest oxygen saturation is 71, and the total hypoxemic burden is 41% of the sleep time, that is 74.9 minutes. So why is it important to look at all of that? Is because the ODI, mean saturation, and the hypoxemic burden will tell us about whether that our patient is at higher risk of chronic complications of sleep apnea. And if the lowest saturation is less than 80%, it tells that your patient might develop acute complications of sleep apnea. And what are they? These are the list of acute complications, which is the acute coronary syndrome, arrhythmias or strokes, and pulmonary hypertension, the neurocognitive impairment, which are chronic complications. Right, moving on to the EEG data, we should know what is sleep efficiency. That is the time you from the total sleep time, the total amount you have slept. So if it is more than 80%, it is normal. Sleep latency is from the time of switching off your light to the time you you record any of the sleep to where you find that your patient has slept. So it should be between 10 to 20 minutes, usually less than 30, and REM latency should be 60 to 120. Why these are important? If your sleep efficiency is normal and your patient comes and tells that, no, I didn't sleep well during my study, then you can reassure your patient that, no, you have slept well, and it is good for me to, the data is more than good for me to report, but you must have felt so probably, or the patient must have felt so probably because he has interrupted sleep due to sleep-related breathing disorders. Right. So in this patient, the sleep efficiency is normal, and then you have the sleep stages. So the sleep stages, I will not go into detail, but you should know that rough percentages in each stage. You know, we have REM sleep, non-REM sleep, and usually REM sleep is well preserved across your lifespan, but N3 sleep will decline with age. And the sleep architecture we see in a chart plus a pie chart, a table plus a pie chart, and this will give a lot of data, but due to interest of time, I will not be able to go through much of the interpretation here. And here also you can see that we can get the same idea using the hypnogram as well. Now in this patient, you can see that the REM sleep is 0%. Now, the importance in this patient is this patient would be a patient who has severe neurocognitive impairment, and the importance is once you put them on CPAP treatment, if this is severe sleep apnea, your patient will start having REM sleep, and REM sleep is dreaming sleep, and they will start saying vivid dreams. So they will think it's due to CPAP. So make sure you look at this and warn your patient you might see vivid dreams within the initial few days of your treatment. And then arousal index is also quite important for us to look at. And the EMG data will tell us about the limb movements, whether you have periodic limb movements, and also parasomnias. We're looking at the video, we can look at for sleepwalking, sleep talking, bruxism, and REM sleep behavior disorders as well. So here the limb movements are high, but there is no recorded PLMs. So we classify according to the number of PLMs, and there are various associated conditions with periodic limb movement disorders. So we'll have to look for these, and especially the most important, iron deficiency and diabetes mellitus can result in PLMs. Last, we are looking at the ECG data for tachyarrhythmias and bradyarrhythmias as well. Your sleep report will show the tachyarrhythmias and bradyarrhythmias, what you see. So in summary, you should be very methodical when you are reporting your polysomnography report, not to miss important information when you're reporting, and go by respiratory data, oximetry data, EEG data, EMG and video data, and the ECG data. You can choose the way you report your sleep study, but please don't miss any of these. So due to the time constraints, I could not elaborate a lot on the sleep architecture problems, the sleep pattern problems, but there is lots of information we can get from that, including what the medications would do to our sleep stages. Thank you.
Thank you very much, Dr. Wadasinger, for that excellent overview of sleep studies. I wish I received something like this when I was an advanced trainee. I would now like to introduce our next speaker, Professor Jorg Steyer, who's a professor of respiratory and sleep medicine at the United Kingdom. He's going to talk to us about new treatment modalities for sleep-disordered breathing. He'll be joining us online.
Yes, and good afternoon from London. Can you hear me well?
Yes, we can.
Thank you. So thanks very much for the kind invitation to talk to you today, and looking at you from far away. I wished I was there. I hope you have a great conference. I will talk to you about new treatment modalities for sleep-disordered breathing over the next 20 minutes. So from the background, of course, we are aware that obstructive sleep apnea is a highly prevalent condition. In an earlier talk, it was linked to obesity, and we have seen that over the last 3 decades, the prevalence of obesity has risen. With the data that we have from the countries indicated here, we guesstimate that about 1 billion people on this planet suffer with obstructive sleep apnea. We have very good treatment, established treatment, and as a respiratory physician, there's no better thing than having a patient who comes for CPAP therapy, uses it, and is treated. But unfortunately, it's not always that easy. In a review in our service, we've seen that after 3 months, only about 75% of the patients, and after about a year, really just 50% of the patients who are offered CPAP therapy still use it to the point that we would say there's a treatment effect. And this is in line with big data from the US, here on a study with 2.6 million patients who were reviewed remotely, and only after 90 days, 74.6%, so 3/4 of the patients were still deemed to be adherent to the treatment. If you look into age and gender distributed over this figure here, then you would say someone who might be elderly and maybe possibly male with a rate of 80% adherence at 3 months is typically well treated. But if you happen to be younger in the 18 to 30-year-old group and you may be female, then an adherence at 3 months of just above 50% gives you the idea that if we neglect half of the population that we should be treating, then we are missing out. Big deal. This was here on 790,000 subjects. So we need to think about alternatives to CPAP therapy. And just like in other chronic conditions, think diabetes with insulin. We've got very good treatment, but by now we're not only talking insulin. And I think we're now entering the era of post-CPAP therapy or non-CPAP therapy, in addition, of course, to CPAP, which should still be the first line. So from a physiological model, I don't want to bore you with this kind of very simplified model, but just to give you an idea about the background of what I'm going to talk about. The central nervous system sends a drive to our muscles, and the muscles have to cope with a certain load, and they have a certain capacity to recruit from. And when the capacity matches the load, this is called the load to capacity model of the respiratory muscles, then our breathing is eupneic, we are without symptoms. This situation can change with an increase in load or a reduced capacity due to multiple reasons. And we need to recruit more drive to breathe, to recruit more capacity. And if that's happening, that's fine. But if it's not happening, and that's where sleep kicks in, because with sleep onset, our drive to breathe is diminished. Then we might have symptoms whilst we're awake. That would be breathlessness, but by nighttime, this might be respiratory failure or sleep disordered breathing. So I'm going to talk to you about electrical stimulation of the skeletal muscles, something that has been done since the 18th century, here shown by a physiological experiment by Luigi Galvani, who happened to see that actually whilst he was experimenting with conductors on the kitchen table, whilst his wife prepared frog legs, the dead frog legs started twitching. So this is possible, but why has it been used in treatment in sleep apnea patients so far? This was here the first statement in 2011 by the ERS, the European Respiratory Society. And at that time, there was little evidence. It was stated apnea-triggered muscle stimulation cannot be recommended as an effective treatment at the moment, grade C. On the other hand, you've got the patients, and when you show them actually treatment modalities, here in 200 patients who were adherent to CPAP therapy, then actually only the minority would continue with CPAP therapy. Some would try mandibular advancement devices, but many of those who you showed actually electrical stimulation with hypoglossal nerve stimulators or a TENS machine would opt to give it a go if there was the possibility. So what does hypoglossal nerve stimulation mean? Here, if you look at the cross-sectional cut of the upper airway, then you can see on the muscle fibers of the genioglossus muscle in the tongue ground, the arrow indicating where gravity pulls the tongue ground back and where the upper airway may occlude. Now, if you contracted this muscle with electrical stimulation, then it would shorten and it would not pull the mandible where it inserts backwards. It would actually pull the pharyngeal wall forwards and open the airway. And by now there are different devices. After Apnex failed with an RCT, Inspire is now on the market in many healthcare systems. Nyxoah is in the midline, implanted with a battery pack that's via induction, providing the energy at night. And Imthera is the latest kit on the block. I'm going to talk about the RCT data of all of these devices. So here, this was 2014 in the New England Journal of Medicine, the STAR trial, where Petztrolo et al. Reported on the data of an implanted device with a sensor lead to sense inspiration from the chest wall muscles and pacer subcutaneously inserted to reach the distal branch of the hypoglossal nerve, which stimulates the genioglossus. What they found was that the apnea-hypopnea index in both the treatment and the control arm improved significantly whilst stimulation was provided, but then at 1 year they withdrew the first 50 subjects and randomized them into therapy withdrawal arm and ongoing treatment. And you can see here that with the red bars, the patients where the device was turned off still had the sleep apnea, whilst in blue, the patients where the stimulation was still provided were still reasonably well treated. Based on these data, the US FDA approved the device. And then in 2020, here, the genio stimulation system by Nyxoah published data in a single arm trial without control group. They implanted a midline device reaching to both hypoglossal nerves on both sides with a battery pack on top at night, and found that there was also a significant reduction in the AHI. Most recently, the targeted hypoglossal nerve stimulation therapy, the THN therapy with the Imthera device, published their data last year in JAMA ENT. And here you saw that with the implantation and the stimulation at month 4, there was a substantial reduction in the apnea-hypopnea index, whilst those where the device was inserted in the first 4 months, not activated, still had significant higher levels of sleep apnea. And when they were activated at month 12 and 15 follow-up, they were similarly well treated. Now, in parallel to the implanted device story, particularly our group, but others as well, have worked on less expensive machines, TENS machines, transcutaneous electrical nerve stimulator machines, and have shown some promising data, because although you possibly are further away from the muscle, from the end organ while stimulating, you can still reach the genioglossus muscle via a submental approach. So we did a proof of principle study, which we published 2011, shortly after the ERS statement in chest. And what you could see here, when we waited until patients at night went into obstructive sleep apnea periods, you stimulated for 10 minutes, and we compared pre to post to during sleep apnea stimulation. You saw that the apnea-hypopnea index quite substantially improved. This is here a picture how this looks like. On the third trace from the top, you can see the stimulation artifact kicking in with 1, 2, 3, and 4 milliampere. And if you look at the second trace from the bottom, then you see an apnea just going into the figure, rebreathing with an arousal from sleep, then another apnea until roughly halfway. And with the stimulation being turned on, flow continues. Esophageal pressure, as indicated by the PE's trace, is diminished, so work of breathing is alleviated, snoring is diminished, and the patient continues to breathe with the submental electrical stimulation. We then took this from a manual activation of 10 minutes to a randomized computer-driven sham controlled crossover trial for a whole night in the sleep lab and had 36 subjects included. What we found was that if you take all comers, there was a very modest effect on the oxygen desaturation index and the apnea-hypopnea index. But when you focused on responders, and roughly half of the group were responders, then there was a much more therapeutic effect in the improvement of the upper airway patency, and the apnea-hypopnea index and the ODI came down substantially. So this was the time roughly that we learned about responders, which is important because if you have, for example, concentric upper airway constriction, then you pull the genioglossus forward, the patient might still occlude, whilst if you have anterior-posterior collapse and you pull the genioglossus forward, then they will respond to this treatment. Now, others have shown by now as well, here a Chinese group from Wuhan, that with a TENS machine, you can substantially reduce the AHI, and with intermittent electrical stimulation, even more so than with continuous electrical stimulation. We have just last year published the results of the Tesla Home trial. So that was transcutaneously electrical stimulation in sleep apnea at home. So that was the first time that we handed out TENS machines into the community for 3 months and followed patients who were either using the intervention, the Tesla treatment, or who continued to use usual care, which was CPAP therapy. But the indication here was that the inclusion required that patients were low CPAP adherent, so less than 4 hours usage of CPAP therapy. And not surprisingly, many of those who were on CPAP, despite being encouraged, still didn't use it much more so. And that's why actually the improvement in the TENS machine intervention arm was higher than in the control group. So this is envisaged here with the effect on the AHI and the ODI. And similarly, we found a substantial improvement in the Epworth Sleepiness Scale of about 3 points. So if you list all the data from randomized controlled trials, then the effect size or the therapeutic effect is actually more so on the side of the invasive implanted hypoglossal nerve stimulator devices, as you can see here listed up by the STAR trial and the THN3 trial, whilst actually the non-invasive trials might be slightly less efficacious. However, the confidence intervals on the AHI are largely overlapping. And if you look at the BLAST OSA trial, that is the Nyxoah device, the Genio system, then this is not very different to the here red marked transcutaneous trials. A meta-analysis that we've performed over the pandemic indicated that as there are now much more uncontrolled studies out there, there's a substantial treatment effect, the AHI roughly reducing by 25 events per hour. Again, with the same finding as we had from the RCT data, namely that the invasive, the implanted device might be slightly more efficacious than the transcutaneous approach. The ERS guidelines were then updated in 2021, and the recommendation is still slightly against the intervention, but with low quality of evidence. However, if you read the recommendation, it says that hypoglossal nerve stimulation at the moment should not be first-line therapy, but we suggest that compared to no treatment, it should be used as a salvage treatment in patients with symptomatic OSA who cannot be sufficiently treated with positive airway pressure therapy, CPAP or BiPAP, or mandibular advancement devices, and who have an apnea-hypopnea index, ideally below 50 per hour, and a body mass index below 32. NICE has by now issued an interventional procedural guidance, which we now follow, and we have established hypoglossal nerve stimulation as a procedure in our centers, where we now, over the last 2 years, implant these devices and follow up with an audit tool to review our outcomes. And we are soon to join the European Registry for hypoglossal nerve stimulation. Now, if you compare the methodology, then possibly the cost is higher on the hypoglossal nerve implanted stimulators, whilst with a transcutaneous approach, there are very low costs. TENS machines are easily available over the counter. On the side effect spectrum, except for local skin irritation, we didn't find any substantial side effects over now more than 1.5 decades of working with TENS machines, whilst there are about 2% SAEs with implantable device and some more minor adverse events. We have in our center established now a multidisciplinary team meeting where we review patients who do not cope with CPAP therapy. If they do, that's perfect. They go through the regular service pathway and will be followed up in the regular outpatient clinics supported by the CPAP technicians, of course. But if they fail, then they can be presented in a multidisciplinary team meeting where we have established all the different faculties, the respiratory physician, the dentist, the ENT surgeons, the max-fax surgeons. And by now we are reaching out to the metabolic service as well to combine with them the best possible treatment options that we can then decide on and assign to each individual case. Sometimes these are within clinical trials, sometimes they are in already established clinical pathways, but still rather unconventional ones. Now, this is how we think the future will pan out, that besides CPAP therapy, we are talking about non-CPAP therapy, second line, maybe third line, or combination therapies, but there is still a lot of evidence to fill that gap. So in summary, and just a minute short of my time, I hope I've shown you that there is safety and efficacy in the electrical stimulation in obstructive sleep apnea proven in randomized controlled trials. It is important to identify responders to the treatment. There's hardly ever one size fits all, one treatment that suits every patient. So we are actually very pleased about having alternative treatments to CPAP therapy. Ultrasound, endoscopy, and drug-induced sleep endoscopy may be available for the pre-assessment of the patient. Patient and public involvement indicates that there is a need to supply non-CPAP therapies. Patients want this. NICE and the ERS have reviewed the data, the evidence, which is still evolving, but I'm sure there is more to come. So with that, thank you very much for having me, and I hope you have a great conference.
Thank you, Prof. George, to give us a talk about this, what available for the OSA in the future. So for the last speaker, Dr. Chandimani Ondugodage consultant respiratory physician and senior lecturer in physiology. She is talking about clinical dilemma of overlaps in sleep disorders breathing. Over to you.
Right. Thank you, Rishi, for that kind introduction. And I'm very happy to be here today. And I'd like to thank Bodhika and Professor Madhakethara for inviting me to speak at the Sleep Symposium. I think so far the symposium has been quite successful. I see most of the audience either fast asleep or falling asleep. So without further ado, I will move on to my topic. So I will start with a clinical scenario. This is a lady who came to my hospital last December during Christmas time. So she's 83 years and she's got a history of COPD, and she actually admitted with worsening breathlessness and wheezing for 2 days. She's somebody who's on home oxygen, and for the last few days before admission, she has noticed that she's had multiple desaturations on her pulse oximetry. And she's got a past history of pulmonary embolism, congestive cardiac failure, hypertension, and she's also an ex-smoker. So these are the investigations. So you can see her hemoglobin is slightly low, inflammatory markers are slightly raised with a CRP of 23.4, potassium slightly low with a little bit of low albumin. So she had a blood gas which was done with an FiO2 of 28%, and you can see that the pH is normal, but PCO2 is 7.93. These are kilopascals, which is what we use. And so it is slightly raised, and she's hypoxic, and she's got a bicarbonate of 34.7. So you can see that she's got long-standing type 2 respiratory failure. She had a sleep study done about 2 months before the admission, and you can see that she's got an apnea-hypopnea index of 91.2, indicating severe obstructive sleep apnea. So if we look at the respiratory problems that this patient has, you can see that she's got severe OSA, and she's come in with an exacerbation of COPD. So together, we call this the overlap syndrome. So over the next 20 minutes, I'm going to talk about the clinical dilemma of overlaps in sleep-disordered breathing. So overlap syndrome, what it simply means is when you have obstructive sleep apnea, if it coexists with another respiratory disorder, mainly COPD, or asthma or interstitial lung disease, the burden is more, and it is called overlap syndrome. So if you take obstructive sleep apnea, which is very prevalent, and the global prevalence is about approximated to about 1 billion, and if we look at our population in Sri Lanka, this was a study that we conducted some time ago, and 16.8% is at risk of having obstructive sleep apnea. So I'm going to talk a little bit about OSA COPD, the 3 overlaps, and a bit on OSA asthma and OSA interstitial lung disease. So if you take OSA COPD overlap, the coexistence was first described in 1985. And as you know, both diseases have a very high prevalence. But in order to understand the impact of these 2 diseases coexisting in a single patient, we need to understand a little bit about sleep and its effects on respiration. So when you're asleep, there's a lot of changes occurring in your lung mechanics. So there is a reduction in the ventilation-perfusion ratio. There is reduced end expiratory volume and reduced functional residual capacity. And you know the respiratory drive is also diminished. The chemoreceptors, which are supposed to be sensitive to hypoxemia and hypercapnia, are blunted, so they don't work as well as they do while you are awake. And we know that there is reduced respiratory muscle activity, and mainly during REM sleep, the respiratory movement is entirely dependent on the diaphragm. So when this happens during sleep, obviously, so there is alveolar hypoventilation, and which is leading to partial pressure of oxygen in the arteries reduced, and there is increase in partial pressure of carbon dioxide in the arteries. But in normal people, this is mild and very easily compensated, so you don't really see much changes. But in a patient with COPD who has bronchitis and emphysema with altered lung functions, there are significant changes. So we find that patients who have COPD, they have frequent awakenings, and they have reduced sleep efficiency and quality, and they have a reduction in REM sleep, because REM sleep is the time where they are mainly dependent on their diaphragm activity, and they have increased nocturnal hypoxic burden. So because of this, there's an increased risk of exacerbations in COPD patients, increased hospitalizations, increased cardiovascular events, mortality, and poor quality of life. Now, if you look at the relationship between obstructive sleep apnea and COPD, certain factors that in COPD actually promotes the development of obstructive sleep apnea. For example, the fact that COPD patients are on steroids, and most of them are smokers, and also the rostral fluid shift. But certain factors in COPD actually protects them from getting obstructive sleep apnea. They have lung hyperinflation. When your lungs are hyperinflated, it pulls, it exerts a traction on the upper airway, so it tends to open up the upper airway, thus protecting them from obstructive sleep apnea. And COPD patients tend to have a low body mass index. And then they have, as I mentioned before, they have reduced REM sleep. And we know in OSA, most of the features are aggravated during REM sleep. And also treatment with theophylline that tends to act as a respiratory stimulant. But now when you take these two together, they have hypoxia. So you get intermittent hypoxia in obstructive sleep apnea. In COPD, you would have persistent hypoxia. So when there's hypoxia, there is oxidative stress, and then leading to increased inflammatory markers as well as sympathetic hyperreactivity. So when you put these together, what happens is there is endothelial dysfunction, formation of atherosclerotic plaques, which increase the risk of cardiovascular disease. So it's very interesting. The patterns of nocturnal desaturations are different between OSA, COPD, and patients with overlap syndrome. In obstructive sleep apnea, like Dr. Delisha explained during her interpretation of sleep studies, you see there's intermittent hypoxemia with normal in-between saturations. In COPD, there is sustained oxygen desaturations with worsening in REM. So when you have these two together, in combination, the outcome is far worse. So how do these patients present? So interestingly, in patients with overlap syndrome, the OSA symptoms are less. So in patients with classic OSA, they have a lot of daytime somnolence. So this you don't see so much in patients with overlap syndrome. And they have a higher prevalence of nocturia. So it is very important when we are assessing our COPD patients to be aware of this, that they may have very mild symptoms of obstructive sleep apnea. But if you look at their PSG, the PSG parameters are far worse because they have a lot of hypoxemia and they have worse sleep quality. And also, if you look at their sleep efficiency in their PSGs, it correlates better with their hyperinflation than the AHI or the nocturnal hypoxemia. So what are the complications? So there is a higher prevalence of comorbidities than either one alone. So they have a higher prevalence, obviously, of getting pulmonary hypertension, right ventricular remodeling, and also arrhythmias such as atrial fibrillation, higher hospitalization rate, and worse mortality. Now, what about screening and diagnosis? So there are certain clinical parameters that should make you think whether your COPD patients have underlying obstructive sleep apnea. So obviously, if they have obstructive sleep apnea symptoms, the cardinal features of snoring, apneas, and excessive daytime somnolence, it's easy. But like I mentioned, they don't get a lot of daytime somnolence. If the patients are obese with a high BMI or even a higher neck circumference, you can think of obstructive sleep apnea. If they have deranged blood gases, but then again in COPD also you would have deranged blood gases. And this is also very important, signs of pulmonary hypertension and right heart failure. If it is not keeping with the degree of emphysema that you are seeing in your CTs and also not in keeping with your lung function findings, and the presence of polycythemia, and also use of opioids and hypnotic medications for some other reason, then you have to think whether they've got underlying obstructive sleep apnea. And the comorbidities like uncontrolled hypertension, atrial fibrillation, heart failure, diabetes, stroke, and end-stage renal disease, because some of them too are risk factors for obstructive sleep apnea. Then what about the screening questionnaires that we commonly use, the Stop Bank, the Berlin? So interestingly, the screening questionnaires, the use is limited because the ones that are relied on the features of daytime somnolence are not very useful in here because you don't get a lot of excessive daytime somnolence in this category of patients. So when do we think overlap syndrome in a patient with obstructive sleep apnea? So if they have a significant smoking history, you have to think whether there's underlying COPD. And if they have prominent respiratory symptoms, and if they have a greater nocturnal hypoxemia than what you would expect, and also in your titrations or when you use CPAP, if they need unanticipated oxygen, then you have to think whether there is underlying COPD. So how do we diagnose? So ideally with polysomnography and carbon dioxide monitoring, because home sleep tests are not really recommended when in this category of patients. Like Delisha mentioned earlier, so we do not do the EEGs in home sleep studies, so we don't really record sleep, so we don't see the arousals. And these patients, they tend to have more hypopneas than apneas. And one of the criteria for diagnosing hypopnea is the reduction in airflow with 3% desaturation and then an arousal. So this will not be recorded in your home sleep studies, which would underestimate the apnea-hypopnea index. So what are our goals of treatment? To improve sleep quality, improvement in the blood gas, improve quality of life, and to reduce morbidity and mortality. So one thing would be to optimize the medical therapy for COPD. And the theophylline have shown improvement in nocturnal desaturation as well as the apnea-hypopnea index. And pulmonary rehabilitation has shown to improve sleep quality and daytime somnolence. What about positive airway therapy? So when you are recommending whether to go for CPAP or BiPAP, one of the things you could look to see which is what is the overlap syndrome phenotype that you are dealing with. So if it is more OSA predominant, then you can think of giving CPAP to prevent the upper airway collapse. But if it is more severe emphysema predominant, you might want to consider to start off with BiPAP. So one of the important things is to the PEEP level or the EPAP level, because as you go on increasing the PEEP, it may worsen the hyperinflation in this group. And PAP therapy has actually shown to improve the admission-free survival, hospitalizations, 6-minute walk distance, and ABG and FEV1. But one of the main problems is the adherence to therapy. What about LTOT, long-term oxygen therapy? It is known to improve survival in COPD patients, but in inappropriate LTOT in patients with borderline hypoxemia and overlap syndrome may increase the mortality and hospitalizations and acute exacerbations. So it's recommended to give supplementary oxygen if they continue to have hypoxia, even while on CPAP with a target of 88 to 92%. So that is really about COPD and OSA coexisting. Just a little bit about OSA and asthma overlap. So again, these two there's a high prevalence in both disorders, and they have certain shared risk factors like rhinitis, GORD, and obesity. We know for this for asthma anyway. And so the clinical presentation, this group may have a higher BMI and worse daytime somnolence, frequent exacerbations, and difficult to treat asthma. So one of the main things that we do look in patients where we cannot control their asthma is to see for underlying obstructive sleep apnea. So again, the PSG will show majority of the events are hypopneas with arousals. So this will be underestimated in home sleep studies. So again, what are the consequences? So there's increased exacerbation risk, reduced quality of life, and accelerated decline in FEV1 in those with overlap syndrome. So treatment of OSA will improve asthma-related quality of life, and this effect is more so in those with severe OSA or those with poorly controlled asthma. So just to briefly touch upon OSA and interstitial lung disease overlap. So interstitial lung diseases, so this is actually something that is really coming up. So IPF and idiopathic pulmonary fibrosis and OSA do coexist. So a lot of studies gave a varying of prevalence. It ranges about 50 to 90%. And OSA in IPF is associated with clinical decline regardless of the IPF severity. So if you look at idiopathic pulmonary fibrosis and OSA, you know that in IPF they have decreased lung volumes because of the fibrosis, and so therefore there is reduced traction on the upper airway, promoting upper airway collapse, and reduced upper airway stability and increased resistance. So all of this actually promotes obstructive sleep apnea. And this is more so during REM sleep. And obstructive sleep apnea, you know, there is intermittent hypoxemia and oxidative stress, and also recurrent stress injury. So these actually can be promoting lung fibrosis. And we also know that OSA commonly coexists with GORD, and GORD is a known association with idiopathic pulmonary fibrosis. So again, this group of patients, again, you will not see the typical symptoms of obstructive sleep apnea, so you have to keep low threshold to investigate them, and they would also have a lower BMI. So no reliable screening tool, and it really requires PSG for the diagnosis. Treatment, of course, it is CPAP, but having said that, it is extremely challenging to give CPAP to these patients because they have irritating cough during sleep, and there may be claustrophobia and insomnia and depression, so adherence again would be a problem. So briefly, I have spoken about the overlap syndrome, and we talked about OSA, COPD, OSA asthma, and OSA interstitial lung disease. So it is a common disorder in patients with respiratory diseases, and presence of obstructive sleep apnea leads to worsening of disease control, symptom burden, cardiovascular risk, and reduce the quality of life. So there is no optimal tool to screen obstructive sleep apnea and overlap syndrome. So clinical suspicion becomes very important, and the diagnosis requires PSG, and the management of obstructive sleep apnea is known to improve the outcome. So thank you very much, and thank you very much for staying up during the talk.
Thank you very much for that insightful presentation on overlap syndromes. And with that, I'd like to open the floor for any questions that we have for our four presenters today. I'll kick off with one question. In the presentation of COPD-OSA overlap syndrome, you presented the patient with chronic hypercapnic respiratory failure with severe OSA and significant hypoxic burden. How would you outline your treatment strategy for this patient, particularly within the Sri Lankan context?
You have actually asked me a difficult question because the patient is actually from the UK. But I don't think it would make much of a difference. So this particular patient, we diagnosed obstructive sleep apnea in her about 2 months ago, but she did not want, she refused CPAP. So after much, although we explained it to her, she didn't want it. So that was not ideally she should be on CPAP, and then to see how she responds to that, and then maybe she would benefit from BiPAP because she's already got type 2 respiratory failure. But it was a little different because she didn't want it. But I think here again, so similarly what we would do is we would like to optimize the management of COPD to see whether what is there, that is something that I did not show, what is the degree of their airway obstruction, to see whether they're on the correct inhalers and the pharmacotherapy, etc. And then also to discuss commencing on PAP therapy.
Thank you.
Maybe I could add to this case. We have looked into patients who previously rejected CPAP therapy on the grounds of claustrophobia or adherence due to discomfort. And if they happen to be either on the OHS side, slightly hypercapnic, or with an COPD overlap syndrome, COPD OSA overlap syndrome, slightly hypercapnic, they do often tolerate BiPAP much better than CPAP, because CPAP eventually, particularly if the patient is also obese, requires often quite high permanent pressures in and expiration, whilst actually a kind of extreme pressure relief with a bi-level PAP is much better tolerated. We've published on this in Respirology 2020 with a cohort study of 52 patients who all were better controlled and more adherent and with the CO2 normalized 3 months on after they'd initially not tolerated CPAP therapy. So I guess, again, the solution is not one size fits all, but whilst maybe patients with a mild degree of apnea-hypopnea index might have alternatives to CPAP on the mandibular advancement device spectrum, someone particularly with a more severe AHI, a higher AHI, possibly obesity, and possibly coexisting hypercapnia might have actually alternatives with an BiPAP pressure mode on a non-invasive ventilator, which is, in the context of COPD, for survival, the treatment of choice anyway. As we know, it reduces mortality.
Thank you, Jörg. While you're on the screen, I thought I will ask you, because polysomnography is not always widely available in Sri Lanka. And I know that we use polygraphy and pulse oximetry in the setting of diagnostics. Would you like to put some insight as to how it can be used in a more effective way in terms of screening our population?
Well, screening is always a big contentious issue, because we still, even in sleep apnea, don't necessarily have the evidence to say that screening is actually cost effective. But then I get what you mean by screening, because we are aware of the high prevalence of sleep apnea patients and the problems in the community. So we want to reach out beyond the sleep lab. We've got a fairly big sleep lab at Guy's, but still we only have 10 polysomnography places. So that doesn't really accommodate a population of several million in South London. So we need to think cleverly about our resources that are available, and what certainly the pandemic had a lot of negative factors, but what certainly the pandemic achieved was that we have started to establish much more home-based sleep studies that we use with wearables, with different novel devices. I don't want to advertise now certain systems. But it needs to be a stepwise approach. I think just like in the therapeutics, that you make use of easily available, widely available, maybe hosted devices, be it only a pulse oximetry. And if that doesn't deliver the answer that you're after because it can be false negative, then you might need to step up to a more sophisticated inpatient polysomnography. You need to be clever with your resources, otherwise you will have a never-ending waiting list, which you may have heard of in the NHS as well. But so you don't want to overspend and get everyone the polysomnography, because otherwise, well, the patients you treat will be well treated, but there will be a long, long queue that you've never seen even in your sleep lab.
Thank you very much to the presenters all for their insight and scintillating discussion. With that, we'd like to close the sleep symposium, and we'd like to present the presenters with a token of appreciation courtesy of the Sri Lankan College of Pulmonologists.
Thank you, speakers, for those illuminating series of presentations. I now cordially invite the chairpersons, Professor Buddhima Nanayakara, Respiratory and Sleep Physician, Associate Professor in Medicine, and Consultant Respiratory Physician, Dr. S. Rishikeshavan, to present the tokens of appreciation to the speakers. May I now invite the speakers in order to receive their tokens of appreciation. Dr. Sharmila Vitana. Dr. Dilesha Wadasinghe. Dr. Chandimani Undugadire. And finally to Dr. George Dyer, who joined us online. Next up, let me invite Dr. Vatsala Gunasinghe to present tokens of appreciation to our chairpersons. Thank you.